want you to contrast that case with this case and then the following one. 77-year-old male, similar to our last case, presents to the emergency department for slurred speech. He noticed the symptoms after waking up when he could not drink his coffee. The night before presenting, he noted that loud sounds were more bothersome. The patient's awake, he is alert. He's able to appropriately answer questions, though his speech is slurred. On examination, there's weakness of the right upper and right lower face. Eye movements are normal, as is the remainder of his neurologic exam. The patient's blood pressure is 126/82. He has a pulse of 65. He's not on any anticoagulant therapy. He has a normal PT and INR. Blood glucose is 98, and a non-contrast head CT is interpreted as normal. For this patient, what would be the most appropriate treatment? Tissue plasminogen activator, intravenous heparin, aspirin, low-dose oral prednisone, or high-dose intravenous methylprednisolone. I think for this case, the best possible answer of those provided is low-dose oral prednisone. This patient's clinical presentation seems highly consistent with Bell's palsy or facial nerve palsy. TPA and aspirin wouldn't be indicated because the patient does not have a stroke. Intravenous heparin is not indicated and is rarely indicated in neurology. And while steroids can be used, it's typically low-dose oral steroids, not mega high-dose methylprednisolone, as we often use in diagnoses like multiple sclerosis. Things I would look for in this case. In our first case, the patient had lower facial weakness only. Lower facial weakness typically represents an upper motor neuron finding, meaning there's a problem somewhere in the brain, in the contralateral hemisphere. Weakness of the upper and lower face indicates there's a problem with the nerve, either in the brainstem proper or more likely in the nerve on its way out of the brainstem through the skull on the way to the face. Patients with Bell's palsy, there is weakness of the stapedius muscle in the ear, so they often report hyperacusis in the day or days before onset of other symptoms. The day before onset, they'll say, loud sounds are really bothering me. The facial nerve supplies taste for the anterior 2/3 of the tongue, so patients with severe Bell's palsy may also report decreased taste in the tongue, though technically sensation of the tongue should remain normal since that's the 5th cranial nerve. So what are we looking for a Bell's palsy? We're looking for patients with upper and lower facial weakness, often with accompanying hyperacusis and taste abnormalities. There's no testing required. This can be a completely clinical diagnosis. So if testing is done, CT scan will be normal. MRI scans may show nerve root enhancement as a result of the inflammatory process. In terms of treatment, at least according to the American Academy of Neurology, treatment is oral corticosteroids within the first 72 hours of onset. There's no specific recommended dose. I think any dose that's offered on the test that's a relatively low dose would be reasonable. There are dose recommendations of 25 milligrams twice a day, 60 milligrams daily, with reductions, but no universally agreed upon dose for Bell's palsy. Though commonly done, antiviral therapies offer no significant benefit regarding facial recovery, though a modest effect is possible and is considered a Class C recommendation. So antivirals do not have to be added, though they are commonly. An exception to that would be a patient with Ramsay-Hunt syndrome, which is facial weakness plus vesicles in the external auditory canal, tympanic membrane, or oropharynx. In those cases, an antiviral therapy should be added. For Bell's palsy, most patients will show complete recovery within about 1 year, with a lot of the recovery occurring within the first few months.